Hi, good evening, everybody, and welcome, and very well done for joining us on a evening at 6 o'clock. But these are always very worthwhile presentations. There is already 2 of these recorded on our YouTube page, but Dr. Kayembe will do a little recap, I'm sure, as we continue with this very interesting diabetic case. Thank you very much for Dr. Kayembe making all the effort to prepare these amazing presentations. I'm very happy to hand over to him now. Dr. Kayembe, you can just unmute, then I can check if I can hear you.
Unmute. Hello?
Hello, there we go. You're nice and clear.
Okay, so this is our 3rd session, and we are dealing with a patient with hypertension, diabetes, lower extremity arterial disease, dyslipidemia. And the first session was mainly focusing on hypoglycemia. Then later on, because the patient was only on sulfonylurea, we reminded one another that the first step of the management should have been metformin based. And as we can see there, we know that metformin is effective, is safe, is inexpensive. And not only it reduces blood glucose, it helps the patient to achieve and attain, depending on the stage of the disease, the glycemic control, but it does also have the advantage of reducing cardiovascular risk by reducing the risk for cardiovascular event and death. That is why metformin is and should, unless contraindicated or unless we tried and it is not tolerated, metformin should be part of the first step of management in every single patient with diabetes. So we ended the 2 weeks ago the review of step 1 in type 2 management based on the SEMSA guideline and even international guideline. So, but we need to remind one another, although we say step 1 is metformin based, we need to be mindful of the fact that step 1 is not always monotherapy. That this was the last slide for last session. So because metformin will not always be monotherapy, we need to know that there are therapies that can be added to metformin as part of step 1 in special circumstances, because that will, once we've offered our patient with early combination therapy in those circumstances, we reap the benefit of extending the time to treatment failure. I hope all of us will still remember that type 2 diabetes is a disease that evolves, and as time goes, oral therapy will fail and we will need to step into insulin therapy. By starting a patient with early combination therapy, we reap the benefit of keeping away or prolonging the time to treatment failure. And so it is important that we know those circumstances that will warrant us not only to offer metformin as first-line therapy, but metformin with additional therapies. And which ones are those special circumstances where metformin should always be considered as part of a combination therapy in step 1? It is when your patient baseline HbA1c is equal or greater than 1.5% above the glycemic target. We all know that we treat to target when it comes to type 2 diabetes, and those targets by default, we always talk about less than 7%, but we know that the target can be less than 6.5 when the patient is younger, when the patient is newly diagnosed, when the patient has a long life expectancy, when the patient doesn't have comorbidities, when the patient is motivated, when there is support, and we have access to all those additional therapies. So if you have a patient that the appropriate target is 7.5, less than 7.5, and you did your patient HbA baseline and it comes back, it is 8.6. So 8.6 is 1.6 above 7, which is the target for that patient. Ideally, you should be considering offering your patient a combination therapy rather than metformin monotherapy. The other, but when you read the SEMSA guideline again, you will see instead of using the 1.5 or more above the target, SEMSA guideline put a blanket 9%. But if you go by 9% and your patient, for example, has a target of less than 6.5, you will deprive your patient that comes with a HbA1c of 8, the benefit of early combination therapy. So whenever this is 9% and the equal or greater than 1.5% above the target are the same, it is almost the same criteria. And I think that choosing 1.5% above the target will benefit most of our patients, and there won't be anybody that will be deprived of the benefit. Another situation where from the get-go, metformin should not be given alone, but combined with another drug, is that when you have a patient with severe hyperglycemia. And what do we mean by severe hyperglycemia? And this is one of the indications of insulin therapy as part of step 1, along with metformin, is that, and this insulin will be given to the patient or even sulfonylurea until glucose toxicity is resolved. So those circumstances are whenever you have a patient with a random blood glucose greater than 17, basically, that patient should be offered metformin along with insulin. You offer to the patient, you sell the benefit of using insulin from the get-go, and you let the patient decide. The other indication will be if your patient have fasting blood glucose greater than 14, you should offer them as part of step 1, metformin with insulin or metformin with sulfonylurea already as step 1. The other indication also is that whenever the HbA1c is greater than 10%, your patient should be offered as part of step 1, along with metformin, insulin, and or sulfonylurea. The other indication is that when you have your patient that have lost weight because of diabetes, a patient that have ketones but doesn't have DKA, or the patient that have hypertriglyceridemia, those patients should be considered catabolic, and those patients will benefit from getting not only metformin, but metformin and insulin or sulfonylurea as part of step 1. And another time that we should always consider to offer insulin to our patient and convince them that it is beneficial for them to be on insulin that will be temporary, will be every time that we deal with patient with symptoms. When they come, they are polyuric, they are polydipsic, those patients should be offered insulin therapy, not that act rapid 10 unit with normal saline, but a temporary intensive therapy with insulin. And this is should be applied not only when we diagnose a patient and we start the patient, but at any time, any other time during the course of the disease. If your patient meet those criteria, kindly remember to offer them temporary insulin to get hyperglycemic toxicity resolved quicker, with in mind that we will pushing far away from the patient failure to oral therapy, because we will be preserving the beta cell function by achieving a glycemic control earlier. So, and if you add to toss and choose between insulin, because I've been saying give insulin or sulfonylurea, we need to remember that insulin has the advantage of being effective where other agents are not. And whenever, for example, there will be an issue about CKD or DKD, because patient can be diagnosed from the get-go with renal failure or with chronic kidney disease, you will have the advantage when you use insulin rather than sulfonylurea. You won't have to care or to worry about how low or how severe your patient renal chronic kidney disease is. So again, there might be people that were present with us during some discussion around early combination therapy. We use only to talk about insulin, but there are more and more data out there, as you can see, that have shown that sulfonylurea can still be as effective as insulin when a patient need early combination therapy and they have uncontrolled hyperglycemia. You can add sulfonylurea temporarily and get hyperglycemic toxicity resolved, and later on you dial back the treatment to go to the standard step 1 therapy. So now, what is step 2? Unless you are part of the professor team, step 2, if you read the current guideline internationally, it depends on, are you in a setting where you have money or you don't have money? Are you in a setting where if you have access to money, you can now start choosing my patient as a cardiovascular arteriosclerotic cardiovascular disease, therefore I need to tailor my step 2 accordingly? Or am I dealing with a patient with heart failure? Then I need to tailor my step 2 accordingly. Or am I dealing with a patient with chronic kidney disease? I have tools that are expensive that I can use to take advantage and align myself to the fact that my patient has chronic kidney disease, to try to further slow the progress or to protect my patient from getting chronic kidney disease. Some other consideration when you have money is that your second step will depend on, can be guided by the fact that you are worried that your patient at risk of hypoglycemias, then you use those drugs that are less likely to cause hypoglycemia, and you offer them as part of step 2. And the other consideration is that if your patients are worried about gaining weight, then you need to go for drugs that are either weight neutral or drugs that will allow your patient to further lose weight. But that is when you have money. And most of the time, patients that we will be dealing with are patients who don't have money, or we will be dealing with patients that are getting treatment in a system with resource constraint. So in this case, when we don't have money, the second step with metformin, which is a step that we need to bring on board as soon as possible. And once you've started your treatment, 3 months down the line, HbA1c should be done, and the decision to optimize treatment taken as soon as possible. We need to get away from dragging time, prescribing treatment that are not effective, delaying optimizing treatment. So as soon as possible, whenever we diagnose our patient, we need to keep in mind that you start step one with in mind that there is a step 1 plus, basically, where metformin will be offered along with either insulin or sulfonylurea. But if your patient didn't meet those criteria, but end up not being controlled with metformin monotherapy, or losing control after being controlled with metformin monotherapy, then you need to step up your treatment and add sulfonylurea to metformin. So step 2, basically in our setting, will be glimepiride along with metformin. And we also know that lifestyle modification, weight management, physical activity, nutrition, medical therapy are all part of the package. So, and step 2, again, it is not it's not without metformin. The only time that metformin will not be part of step 2, it is when it is contraindicated. So we spoke about this already, and or when it is not tolerated. So whenever we see step 2 and we take our patient to step 2, we need to remember that it will be glimepiride with metformin. And talking about tolerance, we should be mindful of the fact that approximately 5% of patients with GIT caused by metformin might be unable to tolerate metformin at all. Just the last week and this week, there is a lady at staff clinic who is struggling. She even chose to stop treatment just because the clinician didn't wanna accept the fact that she was not able to tolerate metformin. So if you force metformin on them, they will go home and they will not take it because they know exactly what it does to them. So we need to keep in mind that yes, we learn some tricks on how to deal and try to resolve GIT's metformin GIT side effect, but we need to be open-minded to the fact that 5% of patients might not be able to tolerate metformin at all. So with metformin, we need to also remember that if you go by the guideline, the sulfonylurea of choice will be glycoside MR. And we need again to remind one another when we say step 2, currently that sulfonylurea should never be glibenclamide. And if you find a patient with glibenclamide, even if they are tolerating, please take that patient off glibenclamide and never start a patient with glibenclamide. So, and because patient can be on any of these 2 drugs as an alternative to glimepiride, let us remind one another the equivalence is that 1 to 2 milligram of glimepiride equate 30 milligram of MR glycoside equate 5 milligram of glibenclamide. So whenever you receive your patient that comes from private, or whenever you have a patient in public that as a medical aid that you wanna offer glycoside to because it is the preferred drug, you need to know how to switch your patient from one drug to another. Again, we say glimepiride is part of the second step on top of metformin, but how much metformin our patient will be on when we give them glimepiride. We need to know that metformin doses will range from, on paper, from 500 to 3,000 milligram of metformin, and 500 milligram being the standard starting dose for immediate release or standard metformin, but 500 milligram is also the starting dose for XR metformin. We discussed the issue and the benefit of XR on immediate release metformin last time. And we know from us to get, from our patient to get from 500 milligram to in theory 3,000 milligram, that is usually not needed. Your patient would have got this treatment up titrated by 500 milligram, not every 3 months, but ideally every 1 to 2 weeks. And titration, it is based on the patient's self-blood glucose monitoring. The 1 week to fortnightly adjustment is based not on A1C, but on fasting blood glucose. So, and the target, whenever you put your patient on a particular dose of metformin, is to get the fasting blood glucose between 4 and 7 millimole. So if you start your patient on 500 milligram because that is the starting dose. A week later or 2 weeks later, the fasting blood glucose is not between 4 and 7. You should increase your patient metformin to 500 milligram twice a day and continue to monitor. So we should run away from starting 500 milligram metformin and forget about it until we will pull blood 3 months later for HbA1c. So that is the maximum range, the maximum dose for immediate release metformin. But for XR metformin, the maximum dose is 200 milligrams. So we need to have this in our mind. So you cannot prescribe the XR metformin and use the 3,000 milligram as a maximum. So, but whenever on paper we read that metformin can be given up to 3,000 milligram, we need to know and remind ourselves that very few patients will have additional glycemic benefit with doses that are higher than 2,000. So basically, you should not be deferring adding sulfonylurea to your patient because you want to get your patient metformin to 2,000, to above 2,000, because very few of patients will benefit from that. And yes, we've seen patients with 2,550 milligram. This is an optimal dose for obese patient, but it is not for glycemic control per se, it is for cardiovascular benefit. So let us again remember that yes, most of the patients will not get any benefit or reap any benefit above 2,000 when it comes to glycemic control, but obese patients should not be deprived when they tolerate to get the metformin dose escalated up to 2,550 because of the cardiovascular benefit. And the warning when it comes to metformin is that the maximum will drop down to 1,000 milligram when your patient has a eGFR that is between 30 and 45, or when your patient is on the dolutegravir. So a patient that is HIV positive and using the dolutegravir who is diabetic on metformin, glimepiride should be brought on board as soon as they reach 1 gram of metformin, and that is the ceiling for this particular patient, and they fail to achieve the glycemic target that we've spoken about, and the glycemic target being now reminded that they should not be deferred to 3 months when we do HbA1c, rather check every 1 to 2 weeks if the fasting glucose is not on target, meaning between 4 and 7, you need to get your patient dose up. So most of the patients will get the target between 1,000 and 2,500 when it's come to metformin. So basically, whenever we put a patient on glimepiride or glycoside, they will have had this range of doses. So those are the range of doses that we might expect our patient to be on when we want to take them to step 2. So it is all about how much is tolerated, because if they only tolerate 500, you cannot push it to 1,000. A little bit of metformin is better than no metformin, but it should be a little bit that is tolerated. The dose that metformin that we have when we start somebody on a glimepiride can be the maximum that is effective for that patient, but the dose of metformin can also be the one that was adjusted because of either the eGFR or the DDI. So now, when do we decide to bring glimepiride on board on top of metformin? The first criteria will be they are on metformin, they got to the ceiling, and the fasting blood glucose is off target, and it has been adjusted, and at 3 months we are at the maximum. the A1C is off target, you need to add glimepiride to your patient metformin. So, and what do you add? That is the range. What do you add as glimepiride? You add 1 milligram. That is the standard initiation dose of glimepiride. But we need also, again, to remember that we should not be square-minded. Whenever your patient HbA1c is still more than 0.5 away from the current HbA1c target, you rather start that person with 2 milligrams of glimepiride rather than 1 milligram of glimepiride. If your patient is symptomatic for diabetes, don't offer that patient 1 milligram because the patient symptom will only resolve quickly with a higher dose. Don't start your patient with 1 milligram, rather start your patient with 2 milligrams. So the lesson here is that yes, traditionally we will start them with 1 milligram, but there are circumstances again that we need to be mindful of that warrant that we start our patient with a higher dose of glimepiride, which is the double of 1, which is 2. So, and we've started with 1 or 2, we will also titrate up glimepiride, this time every week to maximum 4 weeks. So every week, every fortnight, every month, based again on like metformin on self-blood glucose monitoring, you should be able to titrate by 1 or 2 whenever your patient fasting blood glucose, but not the A1C is not on target, the target being 4 to 7. So again, this is something that we need to change, because the earlier our patient achieve the glycemic, particularly the HbA1c target, the sooner they get that, the better for them. Again, what is the usual dose when it comes to glimepiride and achieving the glycemic control? Most of the time, the usual dose for most of patients will be between 2 milligram and 4 milligram. But what about renal dosing? Because patient can be diagnosed with DKD, patient can progress while on treatment and develop CKD or DKD. What are the implications? The implication is that we all remember, it is easy for us, even if we are waking up late at night, to remember that below 45, above 30, we needed to reduce metformin to maximum 1 gram. And below 30, we should not give metformin to our patient. But what about glimepiride? This is the 2 possibilities. They are advices against glimepiride every time the eGFR falls below 30, but there are also some school of thought that it can be, but you need to be cautious and monitor your patient properly, or just reduce glimepiride to a maximum of 1 milligram. So the reason being that glimepiride at a lower eGFR comes with an increased risk for prolonged hypoglycemia that will last more. It is a short-acting sulfonylurea compared to glibenclamide, for example, but whenever it causes hypoglycemia, that hypoglycemia can last more than 24 hours. A reason why your patient who develop hypoglycemia on glimepiride should not be discharged back home, but sent to the hospital for not only correction of hypoglycemia, but also maintenance for 24 to 48 hours, but not less than 24 hours. So especially when they have chronic kidney disease. So remember again, once we drop below 60, it is all about 1 milligram. So whenever we are below 60, even if you consider starting a patient glimepiride, you should never start a patient with more than 1 milligram. And whenever you wanna increase or adjust your patient glimepiride, you cannot adjust by more than 1 milligram. Remember that we say standard, you can even decrease by 2, or you might even start with 2 when the patient is, for example, symptomatic. But when there is a CKD or when the eGFR is below 60, you should not, even if they are symptomatic, you should not give them more than 1 gram. And we need also to remember that once we are below 50, we can just suck it and say whatever glimepiride that we want to give to our patient will be maximum 1 milligram. So, and those doses, those renal dosing are based on the best available evidence currently, and also mainly based on clinical expertise. So those are the things that we need to keep them in mind. There are some of the recommendation and the literature that substantiate those recommendations. This is another reference also on what to do and what not to do, and why not doing it at a eGFR of less than 15. So this is the range of doses of glimepiride that on paper you can see your patient on. But again, we bring here the issue about, should you really go to 6 milligrams? Should you really go up to 8 milligrams? As you can see, there is nothing that you get from glimepiride above 4 milligrams. And we have been learning that we need not to drag our feet. We need to get our patient to target as soon as possible. So why should we be wasting? Because to go from 4 to 8, it means we would have wasted 6 months waiting for us to get to 8 milligrams, while in fact, we might just get 0.1 reduction in HbA1c. So as we're saying, instead of going fast, when you really target to get your patient to 6 or 8, this is literally dragging your feet. And it is not a separate, this should be called therapeutic inertia, because you didn't, or clinical inertia, because although you change on paper the numbers, but HbA1c will not really move that much. And it is not a surprise that many patients, we all know that many patients with diabetes don't achieve the control. And this is just an idea for you. And this is across, being it on oral agent alone or oral with insulin or insulin, because we tend not to adjust the patient treatment on time. We only have less than 50% of patients on treatment with diabetes that achieve control. So, and whenever you go like that, you feel you will be contributing to extending the time to changing treatment. As you can see, patients have been subjected to hyperglycemia for long period of time. On average, as you can see, there's 7 years, just because we didn't want to change treatment. And as you can see, especially when you start getting to step, people takes a very brief time to move from one drug to two, but they take longer when the patient is at stage 2, when they have two drugs. So, and one of the things is when you start banking on 6 milligram or 8 milligram for making a difference. So this is our patient. The patient is currently on 60 milligram of glycoside and MR, and 1000 milligram of metformin XR. And the HbA1c done last month came back as 5.8, and she never got any hypoglycemia since the dual sulfonylurea therapy was stopped. So again, just to remind one another that in our case, if you prescribe glycoside to your patient, that will be the range of glycoside that your patient can be walked through. And glycoside is not only MR currently. You will see patients, especially those that are paying for their own treatment from GPs, they don't have access. Most of the GP don't give them glycoside MR. They give them glycoside immediate release, and this is the range of doses. So the immediate release is in 40s, the MR is in 30s. So again, like with metformin, you will change and up titrate your your patient glimepiride dose based on the AC, or based on the fact that you've reached the maximum because of EGFR. And later on, so if you base by your change by on FBC, it means you would have adjusted your patient glimepiride every 1 to 4 weeks. And if you do it by 1 AC, we need to remember that because it's done every 3 months, this patient should at least have been, especially if they are off, that patient should at least been already at 4 milligram by 3 months. So again, like with metformin, when you are at step 2, if your patient meets those criteria that we've discussed before, we need to remember that there is a step 2 plus, but step 2 plus because it is intensive insulin based, it means your step 2 will be almost plus minus, because you cannot give Actrafen on a patient with glimepiride. So your step 2 plus minus will be metformin with insulin. And this should be considered at any time in the course of the disease. Thank you very much.
Thank you very much, Doc. This is an amazing series. And what's great is how it also crosses what happens in private practice, because we do have a lot of crossover with patients that come into our facilities. And many of you might also end up in private practice. So thank you very much. We're really getting into the in-depth of this at the moment. Is there any questions? You are guys are welcome to put it on the chat, or just unmute yourself if you've got any questions at this point. I'm just looking in the chat. There's nothing that's coming up at the moment. And we'll keep you posted about, I assume there's some more episodes to come on this topic, Dr. Kayembe, or are you going to start a new theme?
No, we need to get to insulin, absolutely.
That's what I was thinking. Great. So we'll let you guys know in terms of the next date. I don't see any questions at the moment, so I'm going to close this meeting now. Thank you very much, Doc. This is very, very useful. And again, we will send the link as well of the recording for those of you that want to revise things or to pass on to people who weren't able to join us this evening. Good night, everybody, and thank you very much.